Good morning, good afternoon, good evening, everybody around the world. We are excited to have you all with us today live discussing the management of fistulae. We have three wonderful clinicians on the call today to share their expertise from around the world, from the US, UK, and India. And we have a very brave and kind patient, Sandhya, sharing her journey living with fistulae. I'd love to get us kicked off today with some introductions. Dr. Deepak, would you like to just share a little bit about yourself and your background, and then we'll move to Dr. Janindra, Dr. Vishal, and Sandhya, please.
Sure. Tina, first of all, thank you for inviting me on this webinar on a topic that's really of close interest to me, both from a research standpoint and of course, from a clinical standpoint as a clinician. So I'm a IBD-focused gastroenterologist and researcher who's based out of Washington University in St. Louis in Missouri, United States. I have a focused interest in both clinical management and research on visualizing perianal Crohn's disease. And I'm also one of the sites part of an international fistula consortium called the Top Class Consortium, led out of St. Mark's, London. Thank you.
Thanks so much.
I'm Vishal Sharma, and I work at PGI in Chandigarh, which is in the northern part of India. Again, I focus on IBD, and because GITB is a close mimic, so I also work on GITB, which is a close mimic of IBD. And I haven't as much into perianal Crohn's, but we are seeing an increase in Crohn's and also perianal Crohn's in northern India. In South India, it's already a huge problem, especially in Kerala and Tamil Nadu. But now increasing in, and even papers have started coming out of North India. So I think it'll be, I'm happy to participate, and I think it'll also be a learning opportunity for me.
Thank you.
So I'm Janindra. I'm one of the colorectal surgeons, and my specialty interest is in IBD. So I do deal with the abdominal side as well as the perianal side, and I'm the lead IBD surgeon at St. Mark's Hospital in London, which is the premier bowel hospital in the UK at the moment. We do a huge amount of research as well as a massive clinical commitment to IBD patients. So thank you very much for actually having me, and it's a great pleasure to be here and to see what I can share from our experience.
Thank you so much.
Hi, everyone. I'm Sandia. Thanks, Tina, for having me over today to participate in this forum. I am a biotech sales specialist living in Boston area. And I am, a recent patient, if you will, of perianal Crohn's. But when it came with a vengeance. I have had about 10 surgeries in the past 2 to 3 years, and recently a colostomy just because of the complications of perianal Crohn's. So I'm really looking forward to being in this forum and learning about this and sharing my views as well. So thank you again.
Thanks so much, Sandhya. And thank you to all four of you for being on this talk. It's a very, very difficult topic to talk about. And I recognize that as myself, as a Crohn's patient living with multiple perianal rectovaginal fistulae, how hard this is to talk about and what a number it does on our quality of life. And it is very, very important to have these open conversations with both our GI and our surgeon to understand what are next steps. How is this going to be treated? How many surgeries am I going to need? So we're going to be talking about a lot about fistulae and the treatment and management, but really wanted to kick off with a Fistula 101. So Dr. Deepak, Dr. Vishal, can you both tell us a little bit about what is a fistula? How do these fistulae get started? How do they form? And does a fistula always mean that you have Crohn's disease? If one of you doesn't mind going through that with us.
Sure. I can kick it off. So I think your first question of what does a fistula mean? So just to be very technical about it, there's obviously a natural track, which is the GI system going from mouth to anus. So traditionally, a fistula is defined as something that's a tunnel-like track that is not the normal track. So it's arising from, in this case, the GI system could be anywhere, technically could be anywhere from the stomach, small bowel, colon, or from the rectum area out to a different site, which could be another internal organ, which is then defined as an internal fistula from, let's say, stomach to colon, or small bowel to colon, and of course, more devastating complications such as fistula from small bowel to the urinary bladder or some of the female reproductive organs, or in males to sort of the prostate, penile area, penoscrotal area. So now perianal fistula specifically goes to the fact that it's arising from the rectum or somewhere close to the rectoanal verge out either to the skin, or it could also be going to the penoscrotal area, or very rarely to immediate close organs. So that's sort of the general classification of fistula. I mean, there's obviously more technical classifications based on whether the fistula is sort of outside of these muscles that you normally need to control bowel movements, which are called like your sphincters. So there are some which are within your control, which is the external one, and then there's a sphincter that's sort of not really under your conscious control, but is sort of in the control of the nervous system, which is called the internal sphincter. So based on that, we classify things. Now, a fistula in in sort of the internal organ is a little different in how it arises. And this is an area of active research, so it's not like we know everything for a fact, but let's say fistula arising from internal organs often tend to have a narrowing kind of below that. So there's often a narrowing called as a stricture. And
Yes.
in some ways, you can almost think of a fistula from a higher up internal organ arising because of the pressure effect. And it's getting relieved by the fistula. Now, how the fistula arises in the perianal area is probably a little different. And, it's more part of the direct pathogenesis of Crohn's disease more so than a pressure effect. But again, this is an area of active research. And your last question of are all fistulas Crohn's disease? They're not. In fact, most common fistulas, and definitely, I think this is again something I also get Vishal and Janindra's thoughts on. But the most common fistulas, especially probably from a surgical standpoint, are actually not Crohn's disease. These are more sort of the common fistulas called cryptoglandular disease or various other terms, fistula and ano. They are not necessarily because of Crohn's disease, but again, sometimes differentiating that from Crohn's disease would be tough, and that's where sort of the clinical expertise comes in. So I'll kind of stop with that.
That completely makes sense. And thank you for going into such good detail about that for us patients to really understand. Dr. Vishal, Dr. Janindra, I just want to turn to you. Is there anything you want to add with regards to sort of the diagnosis of fistulae? I understand, Dr. Vishal, in India, there is quite a prevalence of tuberculosis, and in much of the developing world, there still is. How are you differentiating between a Crohn's fistula, and does intestinal tuberculosis also come with fistulae?
So fortunately, this is one place where, TB is not a very important differential diagnosis.
Okay.
TB is known to cause fistulae, but I think that is very uncommon. We see a lot of GI TB, but only, I would say, a handful of patients who actually had the perianal kind of fistulae related to tuberculosis. So fortunately, if you look at the literature, there are series, actually large series on perianal tuberculosis also. So,
Okay.
this is a differential diagnosis. Fortunately, it is not very common.
Okay.
So I think in India, TB is always on the mind, but when you have a perianal disease, that tilts the balance towards Crohn's disease.
That makes sense. Dr. Janindra, could you go into a little bit about the complications of fistulae and how you go about sort of diagnosing or understanding, is this Crohn's disease? Is this some cryptograndular disease? Is this something else that's going on? And do you refer to GI when a patient comes to you, or how does this work in the UK? Can you tell us a little bit about that?
Sure. So I think the first thing is that on a first presentation, a fistula is always it's referred to the surgeon. So that's and usually it starts with an abscess or something like that, and that's the first presentation. And we know from our research and from the evidence that there is a lag in those patients, and it's something in the order of 2 or 3% of patients who actually who present with the fistula who will eventually have a diagnosis of Crohn's disease. So it's incredibly difficult to make that diagnosis at the first start. We did try at some marks to actually give a calprotectin to people who came with the fistula just to see whether there was a group of people who we could pick much earlier, because there's a lag sometimes of up to a few years before we make that diagnosis. And actually, it was incredibly rare to get a positive calprotectin in patients who presented with fistulas or abscesses. So it still means that it's incredibly difficult. So it becomes a diagnosis that you really need to make based on what happens after. So if you find it difficult to control a fistula surgically, then you start to think about it. And that's when we're encouraging people to take more biopsies of that region. Now, a biopsy is not always a definitive diagnosis, but that's the point of time where you start to ask people to have calprotectin, colonoscopies, and so on and so forth, where you find that the fistula is getting harder and harder to control and requires more than one operation in some circumstances.
That makes sense. And we're going to go in more into the detail of the treatment and management of these kinds of fistulae. But I think there's two very important points that you all are bringing up, that sometimes a patient without any other Crohn's symptoms can present initially with a fistula, and they can present originally with an abscess. Do one of you mind explaining what is an abscess so our patient population can understand? Maybe Dr. Deepak?
Yeah, I was going to say probably Janindra, since he probably does a lot more of the abscesses first. So maybe I'll have him take that first.
Sure, sounds good.
So basically, from the perianal sense, an abscess is where you will get a lump that's an infective lump just right on the anal region. And usually people will present with pain in that around the anal region, sometimes with a fever, but not always. When you examine that area, there will be a bit of redness and hardness, and over a couple of days or so, it becomes something which is a little bit more fluctuant, and that's when you know that the fluid part of the abscess has. But it's essentially the start of an infection that eventually gets pus in it.
Sure, that makes sense. And then behind that could be a fistula tract, not always, but sometimes, and that is something that you're looking for when you're doing an exam under anesthesia, correct?
Yeah, so that's another debatable topic, whether you should look for it on the first instance or not. And most of us would argue that you probably don't need to look for it, just in case you create a fistula in the process of trying to look for it. So we would usually drain abscesses, leave it be, and then if it's persistent, then go looking for it, because by that stage, and the way I explain it to people is it's a bit like, well, it really depends, especially in the cryptoglandular sense, where the whole process starts. So the argument is that it starts from the glands around the anus, so it's outside the anus, and then you've got something, and it's got to track out, it's got to find a way out, and it either finds its way through the anus or through the skin in that region, or both. And if it does both, that's when the fistula starts, but in the strictest sense.
This makes perfect sense. Thank you for going into that extent and detail. I do want to turn to the patient perspective. Now, Sandhya and I are both patients. We have both similar experiences, but also different experiences in the sense that, Sandhya, I understand that you were diagnosed via the development of perianal fistulae. Is that correct? Do you want to tell us a little bit about that? And then I can share a little bit about my story.
Actually, Tina, I think it's this, we're both the same. So I actually ended up with an abscess. So everything that Dr. Janindra's been saying, I've been nodding my head because I've actually had same trajectory, right? So January 2020, I ended up with an abscess. Not in medical field, so I didn't know what it was. I just, remember thinking, it looks like a cyst. I do get, I had HS, so I do get cysts around my underarm. So I was like, oh, this looks very similar to that. And then, the abscess just grew really fast. And then I ended up going to ER. Did not know anything about a colorectal surgeon. And by the time I went, I was, in a pretty bad shape. I had fever, chills, shakes, in the beginning of sepsis, most likely, according to my doctor. So from then, it was quiet for about 7 months, and my CRS did actually tell me that, similar to Dr. Janindra, that, it's probably just a one-time thing, bad luck. And if you don't get it again, I don't think, we don't have to see you. If you do get it, come back, right? So it was a very similar conversation that I had with my CRS at that time. And, after, it wasn't until a year later that, there was actually a perianal fistula that was found, and we were able to kind of look into, in more detail with that.
That makes sense, Sandhya. Thank you for sharing. I think you bring up a few really good points. So you were diagnosed with Crohn's after developing these fistulae, correct? For me, I had been diagnosed with ulcerative colitis all this time because I had colonic disease. Once I started to develop fistulae, and my fistulae were both rectovaginal and perianal, which means that there was a tract coming from the rectum to the vagina, and there were tracts also coming out, from that rectal area into out onto the skin. So I was dealing with those, and that resulted, along with granulomas and other features of Crohn's, that resulted in a change in my diagnosis from ulcerative colitis to Crohn's disease. The interesting thing, and I think you brought this up in passing too, Sandhya, and I want to make sure the doctors can also comment on this. It sounds like you had hidradenitis suppurativa already, right? HS. That is something that I was diagnosed with later. And it came with, the development of fistulae, and there were some challenges in discerning between what is HS, what is a Crohn's fistula. So I did want to just bring that up quickly too. I don't know who wants to grab this, but maybe Dr. Deepak, Dr. Vishal, is this something that you see commonly with patients with fistulae? Is there any sort of issue discriminating or discerning between HS and Crohn's?
So I was going to say that there's actually good work done on sort of looking at the overlap between patients with IBD and patients with hidradenitis, and there is a significant overlap between the two conditions. I'm not sure that necessarily the pathogenesis is clear yet. I think being able to differentiate hidradenitis, especially of the genital region from perianal, or concomitant perianal fistulizing Crohn's disease is tough. I think that's where sort of ideally working in sort of a multidisciplinary setting with an expert colorectal surgeon, the gastroenterologist, and also I would probably say the third component of a dermatologist who's very familiar with sort of these overlap autoimmune diseases, which share often common etiology between skin and, let's say, the GI
Yes.
system is probably crucial. I think we've all benefited from that cross expertise. So I think that is tough, but I think that's where sort of that comes in, like having, three people coming in with their expertise. I was going to mention here that hopefully in the sort of the coming year or so, we have a sort of an expert consensus document. In fact, that's being led by the group from St. Mark's that's trying to define, and again, this is based on expert consensus, of course, but we obviously need more research to unravel this, but expert consensus trying to come up with major criteria and minor criteria to allow folks outside of, let's say, centers with expertise to try to sort of differentiate or even reduce that lag period Janindra mentioned between the first presentation and the eventual diagnosis of perianal Crohn's disease. One of the criteria potentially could include hidradenitis, for example. So that's something in evolution. But again, I just wanted to mention that.
That sounds great. Thank you for going into that extent of detail. I think just to highlight what Dr. Deepak is saying, sometimes there are extraintestinal manifestations or comorbidities, so additional diagnoses that patients can have, such as hidradenitis suppurativa, but there's other dermatological and rheumatological and other sort of challenges that patients can have, that IBD isn't just limited to the bowel, that sometimes we can have other presentations and sometimes we may need treatment for those other types of conditions. So thank you for going a bit into that. The next thing I wanted to discuss, and this is a question that came in through our Facebook comments. One woman is sharing that her I guess vaginal abscess was diagnosed as Bartholin's rather than Crohn's, and how are physicians discerning between the two of those, and how do you sort of make that judgment call that this needs to be evaluated for Crohn's disease? I'm just wondering who would that be one of the GIs, or would that be surgery?
It's a very, very tough situation, because one of the problems is sometimes you just don't find anything other than that particular problem, like a retrovaginal fistula, for argument's sake. There are certain things, like we discussed before, like hidradenitis, which can give you clues that you have to start thinking that maybe this is not just a Bartholin's cyst or become an abscess or so on and so forth, that it's something else. And I think if you don't have those clues, it becomes incredibly difficult to actually make that diagnosis. And again, even without Crohn's, retrovaginal fistulas are incredibly difficult to fix. The failure rates of surgery are really very high. So that makes it even tougher to actually make the diagnosis. If you have some degree of GI disease like proctitis or anything like that, inflammation of the rectum, then yes, that makes things a bit easier in terms of making the diagnosis. But otherwise, it is tough. And that's why I think you get a lag in most of these situations.
That makes sense. Thank you so much for going into that detail. I wanted to sort of move into treatment and then get more patient perspectives on how this perianal Crohn's was treated for you, Sandhya. In terms of treatment options, I know there's medication, there's surgery. Now that we've talked about diagnostics and what fistulae are, I thought we could talk a little bit about, we could start with medical interventions and talk about surgical interventions, and then maybe hear from Sandia a little bit about this. So Dr. Deepak, Dr. Vishal, I wanted to understand from your perspectives, what are the treatment options that are available for fistulizing Crohn's, both in the US and India? And what that medical toolkit looks like, so patients can understand what first-line therapies might be, what might be options if they don't respond to that first-line therapy. If you could go in a little bit in terms of detail on that. Dr. Deepak, if you don't mind kicking us off with that.
Sure. So happy to do that. And I want to make sure my comments are specific to what's available in the United States. And definitely, I think Dr. Vishal and Janindra can speak more to because there are some differences in what medications are approved in what countries. So in the United States, I will start by saying that while I'm speaking about medical treatment, the reality is that the medical treatment has to be housed within this broader setting of a multidisciplinary treatment plan with close discussions with the colorectal surgeon, and of course your trusted abdominal radiologists, GF pathologists, and the rest. So that's really where I would probably start with that opening statement. And why I say that? Because I would say before a patient starts treatment, and again, I'd love to hear Janindra's thoughts on this. Before a patient starts treatment with a biologic, and with this, so before that, I think you would look at the staging the disease, right? What's anatomy? We haven't necessarily maybe talked about that, so I can maybe address that also. So our standard of care, we would get an MRI of the pelvis, fistula protocol, in addition to the initial exam under anesthesia by the colorectal surgeon. So between the EUA and the MRI pelvis and the clinical exam, you would know the fistula anatomy, and sort of broadly, if you want to say it like a simple versus complex in a simple way, complex means that the fistula is maybe not single, maybe multiple, may have, maybe it's like branching into pieces, things like that. So complex fistulas are probably definitely the ones you would most definitely offer biological therapy with advanced therapy. And I use the term advanced therapy now because there's not only biologics, which are monoclonal antibodies, but we also now have small molecules available. So maybe the term including both is advanced therapy. Simple fistulas, I think potentially that's where the role of the surgeon may be even more so. And again, I won't wade into that, and let me Janindra address that. So some of those patients may benefit from a fistulotomy if it's low and superficial. But again, sort of that's just talking with the fistula, and most patients, 95% and higher, will have Crohn's disease elsewhere. So that would sort of determine the overall treatment, right? Even if it's a simple fistula. Now, complex fistulas, the fistula itself will need advanced therapy to heal. Now, what is healing? Probably is even more controversial topic, and something that Janindra, I, and other people part of the Fistula Consortium are trying to actually address. Hopefully, over the next 5 to 10 years, really drive consensus in that topic. So most of us agree what healing means. Now, in terms of medical therapies, I think the first line therapy I start with in my practice is infliximab, and I use a generic name for it just because now there are also biosimilars available. And in my mind, I really don't have any concerns whether the biosimilar infliximab works as well as the brand name infliximab. Again, I wanted to say that because I know some patients have concerns around that, and at this point, we have good data for that. Why do I choose infliximab? Because that's the one monoclonal antibody that has actually undergone an randomized control trial, which is like the highest level of evidence showing that it actually works against placebo, and was specifically studied in patients with visualizing disease. Most of the data for others in its class, which is those that block this protein called TNF, the data for most of the other anti-TNFs come from like analysis of trial data after the fact, what we call as post hoc, right? And then there are some other therapies like vedolizumab, which has undergone like a smaller open label study, although they studied that with MRI endpoints. So that could potentially be an option, although it's not my first choice of therapy. There's then newer medications that block certain interleukins like ustekinumab, and then more recently we have risankizumab. Now these are again medications I think that probably are effective in a certain subset of patients, but again we don't have randomized control trial data. That's why I don't really think of that as first line therapy. But again, I imagine more data will be generated in the next few years. So if I start with infliximab as first line therapy, I usually use antibiotics in sort of the first 6 to 8 weeks as I'm starting that biologic. Ideally, I'm working with the colorectal surgeon, and we've especially for complex fistulas placed a thread in that fistula what's called as a seton. So ideally place a seton before they start the medication. Start infliximab. I often overlap with antibiotics in the first 6 to 8 weeks. And for the fistulizing Crohn's disease, there is data that has been published that shows that you need higher levels of infliximab ideally to heal the fistulas compared to the levels you need to treat Crohn's disease elsewhere in the GI system. So because of that, I often pair that with a second medication like azathioprine or methotrexate to reduce the chance that the body will produce antibodies against infliximab and you get better levels of the medication. So I often do that. Now, this second medication you could potentially take off 6 months to 12 months on treatment, depending on how your levels are doing, of course, and then go on treatment. And then I usually reassess, obviously, both clinically based on how the patient feels in terms of their discharge from the fistula, their overall quality of life, um, even if, let's say, pain, if they were experiencing that. And I often, at least in my practice, and again, this is not necessarily, I'm not suggesting the standard of care, but I often get a follow-up MRI in about 6 to 9 month period on treatment and try to see if we're clearly seeing reductions in the number of fistula or the length of the tract, or they're starting to look more fibrosed. Again, this is an area of active research. If the first line therapy, for some reason, patient responds, then loses response to it, or they don't respond to it right away, then a potential second line therapy at this point in my mind probably is a small molecule that I would probably go next called, which is a Janus kinase inhibitor called upadacitinib. And why do I select that? It is post hoc data, or data, as I said, sort of generated after the trial was done. So they looked at specifically patients within the trial for upadacitinib, looking at those who had a fistula, and then looked at fistula healing using clinical response. So again, they didn't have MRIs in that trial, right? But they looked at it clinically, and the data appears robust. But again, this is not a specific RCT of upadacitinib in visualizing disease, but the data, that's sort of where it is and where I would go next as second line therapy. Maybe I'll stop at that point and, sort of for Vishal's thoughts.
Yeah, I'd love to hear your thoughts, Dr. Vishal, and then I can go ahead and summarize a little bit of what you both have said.
Yeah, I think Deepak has largely touched upon whatever evidence is available for most of the drugs, and I think in an ideal setting, I do agree that for complex fistulae, which we usually see with Crohn's disease, you end up with antibiotics, ceton, and then anti-TNFs. In fact, this was one of the issues that if you look at the Western guidelines, they have struck off, and actually, I think the ECO guideline has clearly said that thiopurines alone should not be used, although there is very limited evidence to actually support that. And this was one of the things which was discussed during an Indian consensus, which is yet to appear, that given the economic circumstances that we have there, here, many of the patients, anti-TNF is a big deal. It's not available to a vast majority. I'm not even saying a small number don't have access. The majority don't have access. Fortunately, with introduction of the government's Ayushman scheme and some other state level health insurance schemes, some of our patients are who can't afford through the pocket are now getting access to the infliximab biosimilars. But still, there is a group which cannot, and some of my patients are on thiopurines. Again, the first choice remains infliximab for whosoever can get it, whatever way. But then, a vast majority would not be able to continue it beyond a period of time, because the insurance is also for a specific amount, and as it goes out of it, the patients land out of it. So they are kind of maintained on thiopurines. Some of them continue to have a ceton, so that their drainage is maintained, even if we can't give biologics to in hope to heal the fistulae. So they kind of have a chronic drainage kind of a thing. And then I have at least a couple of patients who, even before they could be, given a biologic, have ended up with a kind of, right now I would say, a permanent stoma, hoping that someday, biologic access would be available, and then probably we can think about restoring bowel continuity at some point in future. But the picture is slightly complex here for the lack of access. I'm very hopeful because tofacitinib has been a success story in India, the generic version, and I do hope that there will be these small molecules. They are much easier to produce. I'm hoping that we'll have upadacitinib shortly, and hopefully I believe some generics also coming in, and then hopefully so it will be very different. Like now for ulcerative colitis, tofacitinib is often used before biologics, and I guess once we have upadacitinib coming in, I think even for perianal, probably it will be used before biologics, which are much costly. So this is slightly, but fortunately we do have access to all the diagnostic facilities, including MR, EUS, which is used very infrequently to diagnose perianal disease. So our go-to test is MR, and the surgeon actually, the so-called examination under anesthesia is used very in a limited setting only, and largely when we are putting cetones or doing some drainage or something. Only that point in time that is done. Otherwise, it's not routine to do EUA merely for defining the anatomy. So MR is the go-to diagnostic modality for us.
Thank you, Dr. Vishal. Thank you, Dr. Deepak. Just to summarize some of this for our patient population, I understand that there's significant challenges with, diagnosing and treating fistulae, but it also sounds like there's a lot of challenges in resource-limited settings as well. So a place like India or in the broader developing world, it is very, very challenging, it sounds like, to get the not only the diagnosis, but also get on appropriate treatments. And it is something that SAIA has been working on and will continue to work on, is medication access in this region. It is a very, very important cause, as there are many patients suffering from quite a bit of morbidity due to these fistulae. And that is the prime reason behind doing some education so that patients understand what options they do have. So to summarize a little bit about the medication options, what Dr. Vishal is saying is that infliximab is available in India, as is adalimumab, as are vedolizumab and ustekinumab, but they are financially not accessible to most of the population. So even though they are first, second line therapies, they may not be accessible to populations. So a lot of patients are maybe put on infliximab for a few doses and then have to be de-escalated to a thiopurine like azathioprine 6-MP. What Dr. Deepak has been sharing with us is that there are a number of first line and second line therapies. And I'm very grateful for that, specifically because when I was dealing with this, it was basically just infliximab and adalimumab, and I developed antibodies on both. So this is something that is very reassuring news, at least in the West, until it is more affordable in developing economies, that we have, some of these other therapeutics that Dr. Deepak described. So we have infliximab, we have adalimumab, ustekinumab also has decent data, and we are seeing some data for upadacitinib, which is a Janus kinase inhibitor, an oral molecule, which could be a game changer in a place like India. And we have some data, I believe, on risankizumab as well. So these are some options to consider when it comes to medication therapy. Please note that azathioprine usually on its own is not enough to control this. And it sounds like from what Dr. Vishal is saying, if you cannot stay on a biologic, usually a ceton is placed indefinitely to allow this to drain, prevent an abscess. The patients are kept on azathioprine in a case like that, or methotrexate. Dr. Janindra, I do want to turn to you. We have a bunch of questions about fistulotomies, just trying to understand what are the surgical treatment options, if you don't mind going into some of that. And then Sandhya, I really want to hear from you about what your experiences have been dealing with both medication and surgery. Dr. Janindra, why don't you kick us off?
So the first point I want to make, I want to really emphasize what Deepak started off with, because I think that is the most important thing in managing any IBD related perianal fistulas, is that we've got to work as a team, as a joint team. It cannot be separate. It can't go from physician to surgeon, TikTok. It's got to be together. So Elsa Hart and myself, who's my gastroenterology colleague, quite frequently we run joint clinics, so that it makes sure that the message that comes across and where we're going is always from the same page, so that people don't have to go back and forth. So that's really crucial, especially in the complex fistulas. The second point is the classification of how you sort of put fistulas into categories as to where you're going, because it's really important to understand that as much as we would like to, we can't always cure all of those fistulas. Some of them have to come under what we call symptomatic control to make life better. Some of them are curable, and you can bring them in a loop to whichever thing. And the consortium that Deepak's been talking about came up with a classification which is now published as to where we would put it. So we've got a class A, which is like a minimum disease, and then class 2, which goes into A, B, and C, basically, which is some are curable. I mean, I won't go into the greatest detail of that, but it's just to point out that you've got to be able to categorize people, because one of the big fundamental problems with all of the studies is everyone with a fistula was plunked into one category, and then you're not really playing on a level playing field based on where you sit within that thing. And that's where, because it's been very much medicine versus surgery as opposed to medicine and surgery, which is where I would go with it. Then in terms of the treatment options, based on where the classification sits, is where we would then have to look at what surgical options are. I mean, we very rarely, for argument's sake, perform fistulotomies, because again, if you have wound healing problems or anything like that, so it has to be an incredibly simple fistula where you feel that there is no other disease such as inflammation of the rectum. The ceton becomes the first line option, and that's to allow appropriate drainage, and then you can come back into it from various different points. We do have a lot of minimally invasive techniques like lasers and VAFs, video assisted fistula treatments, which gives us a much better understanding of the way the tracts go and how we can control some of that. Because what I learned from some of the research that I did is that when you're coming to that stage where you're really looking at symptom control, the two main things that patients really want is not always the healing of the fistula, but to control the pain and to control the discharge. And those are the two things that when we know we can't offer a cure, at least we have to go and try that. And then, of course, comes the big issue about stem cells and equivalence of stem cells like platelet derived growth factors and so on and so forth. With the stem cells, you can divide them into what we call autologous meaning it's your own stem cells, and allogenic meaning it comes from somewhere else. And of course, there are multiple studies on it, and from our perspective, from the European perspective, there is a commercially available allogenic stem cell, but it costs 50,000 euros for treatment, and certainly in the UK, it's not approved treatment. The allogenic ones, I mean, it's not approved treatment because they've never really seen the cost benefit of that. And I mean, that's another debate in its own right. But certainly, I think the research for the autologous stem cells are very good as well. So we have that as an option, and we try all those various options in that sense. But the point I'm trying to get at is that there are some people where it works so beautifully, but it's trying to pick the right people for the right situation. That's incredibly difficult when we don't have a clear-cut answer for that yet.
That makes perfect sense, Dr. Janindra. So to summarize a bit, it sounds like surgery is an option. Of course, draining the abscess, placing a ceton if needed, if there is a fistula tract behind it. And of course, there are options of surgical resection or different kinds of options with fistulotomy, fistulectomy, depending on the type of fistula that one might have. And it sounds like stem cells are a promising new option. Can you just share stem cells, they're being used for perianal fistula and for fistula to the genitalia. Is that correct at this time, or is there any broader use for stem cells?
It's mainly for perianal fistulas from the anus or rectum and the vaginal in particular.
That makes sense. And then you are sort of, during an exam under anesthesia, you are placing the stem cells in that region. That's how the stem cell works. Okay, just so our patients, just so the patients can understand how stem cells might be working. So this is a promising new technique that is coming about for our patient population, and I think we are going to be seeing more buzz about this over the next few years. Sandhya, I want to turn to you. I want to understand more about your journey in terms of medications, yes, surgery, yes, but also like the physical and emotional toll that having these kinds of fistulae has taken on you. What has that been like? Can you share a little bit about that with us?
Yeah, absolutely. I think I've gone through everything that the doctors have shared here, right? So it was initial abscess, so I ended up having a drainage, and I didn't have anything, right? Like it was fairly quiet for about 4 to 5 months. And during that time, I had to change jobs, we had to move states. So a lot of stress away from work, right? So you're already stressed out, and with the move and everything. So during this time, I did start having more and more abscesses, and again, coming to a new city, trying to find new doctors. Going to PCP who doesn't really understand the complexity of what we deal with, and finally, just finding a colorectal surgeon who, even at that time, didn't really know that this would be Crohn's, and it was just one of those maybe. We'll see, they did the MRI, they were able to see a fistula, and by then it was a pretty complex horseshoe fistula. So, he suggested a ceton. And during this time, during the move, I had another CRS that I was dealing with in Boston who suggested maybe it's worth getting a GI's input. And like to Dr. Janindra and Deepak's point, having that the balance between both the GI and the CRS where they're talking to each other, right? So once we had that, I think things started moving much more better. But during that time, Tina, it took about a year and a half. It was mentally, physically debilitating. I didn't even share the diagnosis with my closest friends for a long time because you don't really want to talk about butts, right? It's not a fun conversation. Nobody wants to hear about, all of that. So, I would just say, oh, I'm having stomach issues. I'm just having like GI issues, and kind of leave it at that. But it's harder. It gets harder and harder because I was constantly in ER, right? Like I would end up having an abscess, and I would go into ER, and they would drain. I would come back, and I would have multiple MRI visits. And then after a while, you just start feeling just debilitated, right? Like you're at a loss for what to do. It's hard to explain to family. And I think me and you have kind of talked about this a little bit, where we do get a lot of advice, and it's meant very well, but a lot of well, maybe it's something you're eating, right? It's made to sound like it's our fault that this happened. So for almost 6 months to a year, I was in a pretty dark space, right? Mentally, just thinking, what did I do wrong? I had a doctor tell me, well, you're kind of overweight, so I don't think you might not even have Crohn's, because Crohn's patients are generally malnourished and underweight, so you can't possibly have Crohn's. So when you hear even doctors talking that way, you start thinking this is a self-inflicted disease, and that I did something. So there was a lot of not to mention the physical aspects of not being able to do my work. I used to travel. I travel for my job, so getting on the airplane, having a pad over so that it would catch the drainage in case something happened, having huge abscesses and still trying to go to a meeting because you have to, being a mom, being an employee, being a wife, being a daughter, and then it's the last thing you want to worry about, right? So it was very debilitating. But I think once we were able to get into the GI and the CRS talking to one another, I was put on infliximab therapy as well, and then added the methotrexate into that. So started to get a little bit better. But maybe I had about 6 months of break, but during this time I was, I still had multiple cetons. I have multiple fistulae. So it was just never going into this remission that we were hoping for. And it wasn't, and just last year, there was a pretty big one, a pretty big fistulae that developed that was separate from 3 other that I already had. Which was when my current CRS said it might be a time to think about colostomy, because at this point you're on the biologics, you're on all the treatments that is the first line of defense, essentially, and you're still not going into any sort of remission. So that's when I started, kind of I had been reaching out to you guys at SAIA, but really started looking into colostomy just for, maybe this is what I would need to do in order to get that mental peace, right? So that's kind of my story. So
thank you for sharing, Sandhya. Can I ask you how your quality of life and your mental health has been since you got your colostomy? I understand that was just last October. So what have the last 3-4 months looked like?
Yeah, so I got it October 4th. Honestly, it was, in the beginning, it was a little bit of, did I do the right thing? Like, did I, it was almost like a buyer's regret, right? You buy this expensive shoes and then suddenly it's like, oh, I don't think I really need it. So, it was almost like it was an elective surgery. Like, did I do the right thing? Is this, was this the right decision? So first 4 to 6 weeks, I think I was almost questioning. I looked at my colostomy as almost as just a nuisance, if you will, right? But it wasn't until, as you know, Tina, in America, we have Thanksgiving that comes in November, Christmas in December, and every Thanksgiving and Christmas for the past 4 years, I've been in hospital because, either the stress of the holidays or whatever it is, the stress just triggers something, and I have had a couple of ceton placements during the Christmas time prior to that. So, come holiday season, I ended up having a viral infection, and usually that's my trigger to say, okay, body, hang on, we got this. And honestly, that's when I started realizing, while I felt, I didn't feel that great, and I could definitely see there was more discharge and everything else, I didn't go into a huge abscess flare-up, which, I think at that point, mentally it was such a relief, and it was such a almost like that was my shift of thinking of this as a nuisance to it almost being my friend, right? Like it was, and even my daughter, my 10-year-old noticed that, right? She said, Mommy, like, I don't think we should be calling your colostomy bag Lord Voldemort, because it's no longer a villain, you know, it's a friend. So we should call it Pooh Bear, right? So we like it was we almost made that transition, if you will, you know, during the Christmas time, and it's been wonderful, to be honest. So yeah, I mean, I think mentally I'm in a much better space now than I have been in the past 4 years.
I'm so glad to hear that. And I just want to reassure the audience, an ostomy is a treatment option. It is something that can help. And there are certain situations, depending on the location of the fistula. And of course, Dr. Janindra could talk about this more, but depending on the location of the fistula, if it's in your colon or rectum, certain procedures might be necessary. Maybe even a temporary ostomy might be necessary. So I've had an ostomy because of this as well. My J pouch was removed because it was fistulizing all over the place, and it has given me a lot more quality of life back. I am not constantly in surgery, constantly having an exam under anesthesia, or constantly having a ceton placed or an abscess drained. So this is something that I do want to also bring up, that ostomies are a good option depending on the location. Is that correct, Dr. Janindra? If you don't mind just sharing a little bit about that.
Not at all. I think the point that Sandhya made is really important, and that is that, you know, everybody has a time point where they feel this is where I've reached my threshold of every single medication or every single treatment option, and it varies from individual to individual. And our job as clinicians is to make sure that we don't push people one way or the other, you know, that we try and take the journey with them, because otherwise there is a huge negative thing that comes through it as well. So yes, it is a treatment option. Some people will take it a lot earlier and some people will take it a lot later. And it's not for us to make that judgment, because it's very much driven by the circumstances around you as well. So you know, we as I discussed before, there's a whole armamentarium in the toolbox, and it's our job to put it in front, but the final decision making has to come from the person who has to live with the disease, in terms of, this is my time for me.
That's an excellent point. And I think both of you are alluding to some of the social stigmas and challenges we face. And I do want to make sure that we spend a minute just to highlight that. This Crohn's disease is a very, very challenging disease as it is for many of us patients, to explain to our families, friends. As Sandhya was saying, you know, even I called it a stomach ailment, because who wants to talk about butts? Who wants to talk about holes in our butts? And that's very much the reality. Many of my closest friends didn't know about this and have only learned about this through advocacy work that I've done. So it is very, very challenging to share. And I think fistulae are even more challenging, and you know, add that layer of stigma. And then there are the components amongst cultures too. In American culture, this is stigmatized enough. But you add the layer of some of the South Asian cultural stigmas of what are people going to say, that log kya kahenge factor. And that really adds a lot of, do we want people to know about this? This does affect a lot of us. It affects marriageability. We speak to many, many patients who are unable to get married or unable to disclose about their fistulae or get an ostomy because of these effects around marriageability, even getting a job. So these are some of the challenges that our community is facing. We are, of course, here to talk through them and help advise you, but always remember, your health is number one, your well-being, your quality of life is number one. With that, I wanted to sort of start to close up this chat. We have a number of questions, and we're trying to get to as many of them as we can. For the doctors, there is a question about colorectal cancer. Can a fistula result in colorectal cancer? Is this something that you have seen? I'm happy for, I think, Dr. Deepak, Dr. Janindra, Dr. Vishal, any one of you to take that.
Yeah, I think unfortunately, I have seen quite a few. Meaning thereby that for the number of perianal Crohn's that I see, malignancy in a fistula, I would have seen quite a few, meaning thereby that most of the perineal CD remains untreated, ongoing inflammation is there, and I have seen people presenting with malignancy directly. So I think it's important to control the inflammation as well as we can, as early as we can, so that we avoid this kind of a complication, which seems a bit more frequent than it should be with the kind of overall prevalence of perineal CD that we have.
Yeah,
Thank
to
you.
add to, I think, what Vishal was saying, I think, and this might be reflective of how quickly the inflammation gets treated. I guess in the Western literature, fistula cancer, or for want of a better word, a cancer that arises in the fistula tract or sort of close to that, I think it's generally more reported as rare, and that may be something to do with the lag period of recognition and then appropriate tamping down on inflammation. I think one does have to be careful, and this is where again an expert multidisciplinary setting of the GI, the colorectal surgeon, the abdominal radiologist, especially when it comes to the cancer diagnosis comes in, and the GI pathologist comes in, is that you also want to differentiate between perianal fistulizing Crohn's disease, where a malignancy started in the fistula tract, versus a cancer that's fistulizing, around and into sort of around the sphincter. So again, this is where sort of the team would help make the differentiation. I think Janindra made the point of the biopsies, and that might be something maybe for him to comment, that how frequently does someone, biopsy these fistulas, or when should they to look for this. Interestingly, we've had a few recently we discovered where there may be potentially signs on scans in the years leading up to the actual physical, very clear physical manifestation that's obvious on exam. So that's again something that's actually being explored in terms of consensus statements through the same Fistula Consortium group, and also some studies that are upcoming trying to understand the pathology of these cancers and sort of, is there other signs, let's say, especially in centers where serial scans are being done, like can you detect something on a scan a few years even prior to an actual like physical manifestation on exam? So again, more to come on that.
That makes perfect sense. Thank you for sharing so much about the cancer piece. Dr. Janindra, did you want to add anything to that, or should we move on to the next question?
Not a huge amount, except as a colorectal surgeon, you just have to be aware that it can happen, and notice the changes where you start to think this one needs a biopsy.
Makes sense. So there are a few questions around diet and Ayurveda, and I do want to get to those as well, as I know that diet and Ayurveda are big concerns in our community. One thing that I dealt with when I was having multiple fistulae is food leaking through, particles leaking through. What is sort of the recommendation for patients with fistula? Of course, this could be very, very challenging if you have, a bladder fistula, or if you have, other types of fistulae that aren't coming out onto the skin. How should people eat, and what should they be mindful of? Do one of the GIs want to take that, and then we can hear from Dr. Janindra?
Yeah, I mean, for the diet, there is actually some, I would say, limited evidence to suggest that actually EN, observational data to suggest that EN may actually improve healing of perineal fistulae. And even nutrition is a very important, enteral nutrition is a very important part of managing other fistulae also. The question which you raised, that it could be problematic if one is taking too much of fiber, or things which are not digested as well. So certainly towards EN, or let's say easily digested, low fiber, low residue kind of diet may be helpful. But I think there isn't much to go beyond that. I mean, immunonutrition or things like that, they haven't really, there's not much data to really support that. So I'm talking about supplements like glutamine and all. So really no evidence to support that. So we stay on maybe EN for some of the situations where, you may not have access to too many drugs to induce healing of fistulae. But again, you can't have patients long term on such kind of diet. So we don't have a lot of strong data to support any kind of a particular dietary therapy or over a long term for these patients.
Thank you. Dr. Janindra, do you want to talk a little bit about this? Do you use TPN? Do you use, some of these shakes like Dr. Vishal is talking about as well, the enteral nutrition, just for our audience to understand a little better?
Not so much for perianal disease, and we only use PN really if it gets to a point that there is obstructive or some reason why someone can't eat. It's always better to have enteral nutrition if you can, so something orally rather than via the vein system. In terms of managing diet, really, one of the big issues is the diarrhea that comes from a colonic disease and so on and so forth. So if there is something that can manipulate that to make the stool frequency a little bit less, that certainly helps the perianal side as well. And that's the sort of concentration that we would go on. But we're also lucky that we have a very good IBD dietitian at St. Mark's who sort of routinely goes with the patients and sort of modifies things appropriately, and again comes within our multidisciplinary clinics for the more complex patients.
Sounds great. Sandhya, is there anything you've had to do in terms of your diet that you found helpful? I realize most of yours is perianal fistula, so just wanted to see if you had any thoughts on that too.
Not much, Tina. I think I've, since young age, I've kind of suffered from constipation, and then then I would have the bouts of diarrhea, constipation. So it was always again, to make the point that it's hard to say, oh, if you're constipated you'll have this, or if you're diarrhea you'll have this, right? Because I've had both, it's I am a vegetarian since birth, so I haven't really, explored anything beyond that. I do, even after my diagnosis, I tend to just mostly eat rice, dals, the rotis, sabzis. So but to your point, I try to avoid corn and peas and, all of those that just tends to get stuck, or I know that it will cause my fistulas a lot of pain if it's stuck in the tract. So things like that. But I'm hoping to keep the nutrition as minimalistic change as possible, because I want some sort of normalcy, right? And then eating is one way to feel that not much has changed, at least for me.
Oh, no, absolutely. And for me too. And thank you for sharing that. For me, I did have a lot of drainage, especially through the rectovaginal fistulae. Particle size was important. And this is something that I do emphasize amongst patients is if you are struggling with some of these things, or if you have an ostomy, especially an ileostomy, the particle size might be important. I'm vegetarian as well, and I'll end up doing smoothies to try to get my fruits in. And I do very, very well cooked vegetables, small sizes of those vegetables, cut them really small, just to make sure that I can digest them. And of course, chewing well is an important thing for us to do as well, to make sure we're breaking down and getting as much of the nutrients as possible. I do want to close this chat up with one important question around Ayurveda. We have a question on I'm sorry? We have an important question around whether Ayurveda can be mixed with some of these advanced IBD therapies, and if Ayurveda can be used to treat fistulae. I do want to ask our doctors, of course, complementary and alternative medicine is something that our patients do often ask about. It is very commonly used in our South Asian community, so I do want to make sure we address this. Dr. Deepak, Dr. Vishal, if you want to take a stab at this first, I would appreciate that.
Sure. I'll maybe do a quick statement, and I think Vishal probably will have a lot more to add, given he probably sees intersection a lot more in India. I think my general take on complementary and alternative medicine is, obviously some of them may be on the surface sound harmless, versus some on the surface you don't have enough evidence to know if there's like a particular receptor or a pathway there, actually how are they working, sort of, right? And could that potentially create any kind of uh, interaction with the IBD therapy you're on? So my general take on CAM is that the way I address it with my patients, and of course this varies based on the the culture they come from, and that aspect of this is that um, I think if they have a strong belief in the CAM, I would try to sort of see if we can meet halfway, that they be on an effective IBD therapy that I know is supported by evidence. Plus, if they want to do CAM on top of that, I think that's reasonable. And again, I make the point that this is for CAM where I have a reasonable understanding that there is no off-target problems and interactions with the therapy they're on. Now, monoclonal antibodies, in a way, you're lucky that if these are the only two things on board, right? Like the CAM and the monoclonal antibody. The monoclonal antibodies are being metabolized in the body through a whole separate mechanism that doesn't involve the sort of the traditional liver and kidney based mechanism. So that I think you sort of get away with. Now you have to be more careful now with small molecule therapies, because those are metabolized through sort of the standard drug metabolism pathways in the liver. And I think this is especially something also I really hope Vishal maybe can comment on, because again, with increasing small molecule use in India, because that is something that does make me think that if you have a small molecule therapy and a unclear CAM, how might that interact? And so sort of I'll stop there again and maybe let Vishal comment.
Yeah, I mean, we always, want any therapy which works to be used. But the problem is that we hardly have any strong data to support CAM. And unfortunately, this is sometimes, if you don't tackle this question does crop up very often in our conversations. And if you don't tackle it head on, it eventually means that, people might be choosing these less efficacious or not efficacious therapies, which may or may not be safe, over the standard therapies which work. So I think the risk is always there that my advice is usually very clear, that this is what we have, this is the evidence, it works in this % of patients. So for complementary and Ayurvedic so-called alternative therapies, unfortunately that kind of data is not there. And mind you, they're not cheap. They're not cheap at all.
Thank you for sharing. Dr. Janindra, Sandhya, anything you want to add on that front? Otherwise, I'm happy to share my experience too.
No experience on it from my perspective, so thank you.
Makes sense from surgery.
I think, Tina, I think me and you we talked about this a little bit, right? I think our Indian community, especially our relatives, they're very well-meaning. They mean well, but I think sometimes they don't really understand the whole complexity of what we're dealing with. And I have had a lot of my family members tell me that try Ayurveda. You never know. Like, go to India for a little bit and stay there, go through the Ayurvedic medicine, and it's hard, right? It's hard to say no, because they mean well, and sometimes these are very close family members. So it's again, that's part of another mental aspect of dealing with this, right? Because it's you do get a lot of well-intentioned responses like that, and sometimes it's just not very helpful. So I've had to just say thanks, but no thanks. I know you mean well, but it doesn't really help me at this point. And it's hard to do. And I've worked my way up to saying that after 4 years, but it's hard.
Absolutely. And thanks for sharing that. For me, it's more like a nod and smile now. I was very young, like I was in my early 20s when this happened. So I was very, very impressionable. And I was like, you know what? My elders are saying, try this, try this. And I did try this, try Ayurveda, try naturopathy, homeopathy, Chinese medicine even. And I just want to say these are not side effect free. I can tell you that from personal experience. There can be heavy metals. There can be all sorts of things that can affect your liver and kidney function. Do not necessarily assume just because they're quote unquote natural that they're benign substances. There's a reason why we have randomized clinical trials and that we do studies over and over again so that we can make sure we have robust data on some of these medications, on surgeries, on stem cell therapy, on all sorts of things. With regards to Ayurveda specifically, I was doing this hand in hand with adalimumab. Not that, I developed antibodies to adalimumab later, but before I developed those antibodies, I noticed that while I was on some of these Ayurvedic medicines, they were trying to make my immune system stronger while adalimumab was trying to suppress my immune system. And I noticed that adalimumab didn't really have a chance to take off or work on me properly during that time. And I often still wish, would this have worked on me had I not opted to do concurrent therapies with allopathic and Ayurvedic therapies? So I do caution our patient population, be careful. A lot of times we are told that these therapies are benign and harmless, but they can interact with our therapies, and they can certainly play a part in not allowing our therapies to be as effective as possible. So please always discuss and disclose with your doctor. Do not be afraid to do so. It is a very important conversation to have. Like Dr. Vishal said, have those conversations head on. We know our families are, very well-intentioned in wanting us to try these things, but sometimes they just aren't enough for such a strong immune-mediated inflammatory disorder. So these are things that we need to think about. Crohn's and ulcerative colitis are challenging diseases to manage. The longer that we let them go untreated, the worse they can get over time. So it is always best to be in touch with a GI. And if you are dealing with fistulae, make sure you're in touch with a colorectal surgeon as well. I want to take this time to thank our panelists for all your wonderful insights. It's been a pleasure working with you all. And thank you all in our audience for staying on the extra time and learning so much about how to manage fistulae and what fistulae truly are. I hope you can take this knowledge back and apply this for your own lives and to help with our own community. Thank you so much. Take care.
Thank you.
Thank you, Tina. Thank you, Tina. It's been a pleasure.
Thank you.
Thanks.